I'd like to call this meeting to order. Commission Chair Barb Ackenbaum, and I think we ought to start with introductions. I know we do that every meet, but we've got some new faces, and so we don't have to tell who we are and where we went to college. But Don, you can introduce yourself.
John Knight, a relatively new member on the commission for about a year.
Russ Barksdale, Commissioner.
I'm Kelsey. I am at the Health Department. I'm the Sanitary and Health Program Planner.
Welcome.
Amy Lahaney, Director of Health.
And I am Marcy Rand, Director of Human Services.
I'm Maria Maglicano, new to the commission, second meeting.
Hi, I'm Liz Moore. I'm the Director of Community Relations at Silver Hill, visiting here today.
I am Jen Laddick, and I've been on the commission for a couple of years now.
3 years, I think, yeah. Okay, so I'm going to start by going through the minutes. And are there anybody have a change for the minutes?
We have one change from John, where I mislabeled the new Teen Kids in Crisis helpline, the Teen Talk text line. So we're just going to make that change, and then we'll reapprove those minutes the next meeting.
Or I can make a motion subject to the change. I'm happy to do that.
Sort of?
I think that's what we did last time, and for some reason we had to go through reapproving it, but I'll check into that.
Okay.
But meanwhile, do you want to?
I'll make a motion to approve subject to the change.
Second.
All in favor? Okay, thank you. Okay, so I'm going to turn it over to the Health Department, Amy Lahaney.
Great. So we sent out our report yesterday. We're still offering flu vaccines for children by appointment only. We are in budget season, so we presented our budget to the Board of Selectmen and now to one of the committees. And this week we're at the Board of Finance. I participated in the Operation Arctic Blast tabletop exercise, which actually was about freezing cold weather. So it was appropriately timed. And I was there with Marcy and Russ. And that was great. And then we're continuing to monitor our respiratory viral season. I included the link in the report so that everyone can take a look at it and take a look. We're down. Everything's trending down right now, except pretty much RSV. That's pretty consistent. But flu and COVID are back down again. And then we just have our monthly other totals for environmental health. And we had no ticks in the month of January. And then I have Kelsey McCarthy here with me, so she can do a little introduction since she was not here with us last meeting.
All right, so I'm Kelsey. I started back in November. For a little background, I graduated from Fairfield University in 2023, and I started immediately under Amy in the town of Monroe at their health department as a health educator. Then I did a few years of training and became their sanitary and health program planner. And then I became the sanitary and health program planner here in November. So I'm coming up on about 3 months. I do a little mix of the social media and program planning, plan reviews, inspections, and I'm currently working on my food inspecting certification. So it's a work in progress, but we're almost there. And I'm happy to be here.
That's great.
Welcome.
Welcome. Does anybody have any questions?
No,
Healthy?
thanks. And we're excited that you're excited to do some of the communicating, and we were hearing that's something you're good at and interested in.
It's good to have a young person on board.
Social media.
Yeah. I just realized I was remiss. I didn't tell the people on Zoom to introduce themselves. So I'm just going to do that real quickly as Alyssa takes a sip of coffee.
Alyssa McKenzie, Commissioner. Tracy Hamill, first year on the commission.
Jason
Perillo, Director of Strategic Partnerships at Silver Hill.
Thank you. Thank you for being here. Okay, so anybody have any questions about Amy's report?
I just have one question. The winter loneliness and isolation program at Schoolhouse, I was wondering, is that going to be a periodic one or was that a one-off? Because the reason I ask is it sort of ties in with some of the senior work that we were doing in the senior subcommittee, and I was delighted to see it, and I was just sort of wondering whether it was possible maybe at some point in time to find out what might have come out of that.
I'm going to let Kelsey talk since she was there with Shannon on that one.
So it was a one-time thing. She does talks every so often. I think it's monthly at the schoolhouse. And it was actually we had them do a project. I had them write on a slip one thing that they would do this winter to combat loneliness, and one person or place they would go to, to keep them involved in social. And it was I mean, everyone went around and they shared. And there were probably, I think, around 17 people.
Oh, wow.
So it was a good turnout, maybe 13, I don't know.
13.
But a good amount of people. And I thought it was really well. I mean, I'm sure she would be interested in doing it again. It seemed to be well received.
Do you know what their utilization is on like Get About to get them out and about if they feel socially isolated? Do we know that?
I don't know,
Okay.
actually. That is something I can get about.
And congratulations on the
yeah.
Lapham Center and everything of
Thank
that
you.
nature. That might be a good center for talking to John, but social isolation for seniors, if the Get About can do maybe van service and pick up
Well, which
several
they
people
do.
there.
They do.
Yeah.
They do that.
I know they do for appointments.
Yes.
I know they really get about a lot.
Well, and like they
Medical.
will use the Get About for like going to exercise classes and stuff like that with Lapham. So.
Okay.
Yeah, no, that's great. Any other questions for Amy?
I did have one more thing I forgot to mention.
Okay.
Because it just happened this week. The health department, in conjunction with all of the other local health departments throughout the state of Connecticut, is promoting a hands-only CPR video for the month of February, since it is Heart Month.
Oh.
It is a short 1-minute video. It's obviously not like a certificate training program, but it's just to raise awareness about hands-only CPR and to give people a little bit more confidence, and to reacting in an emergency situation. So we have posted that on our social media. We are also sending that out in the First Selectmen's newsletter, and we will also be sending that out from the listserv from our emails. So feel free to do it. It's quick and easy, and it'll hopefully get people thinking about it and maybe signing up for a full CPR AET class if you desire.
That'd be great.
Also, the EMS does, I think, once a month at the library, a hands-only CPR class. So it might be, Nancy Upton is the one who sort of coordinated it, but maybe if you're posting on social media about the video, some information.
I did include a link
You
to
did?
the
Okay,
EMS
perfect.
with the programs, because I
Okay,
saw
great.
that you had a bunch listed, so that if
Awesome.
people wanted more training,
Yeah.
and hopefully that will generate some more interest in town.
It's great. Now, the social media, what platform are you releasing things on?
Facebook and Instagram right
Okay.
now.
Great. All right. Well, thank you. And yes, thank you, Russ, for recognizing that Marcy is now the Executive Director of Human Services and Lapham Community Center. And we're very excited about that.
Good business card.
Hey, I don't know. It doesn't even fit on one line, No, but in recognition of, well, you've got experience running a community center, but also, your work with seniors. And Aggie Aspinwall, whom she's been there, I think, about 10 years, and she's retiring. But it's wonderful to have you more directly related to what's going on.
Yeah, no, I'm very excited and I work really well with Kathy, and Aggie will hopefully just help us do this seamlessly. We don't have an exact date, which actually gives us the luxury of like taking our time, learning the ins and outs of Lapham and, down to like billing and the minutia of like the boring
And you have
stuff.
to learn how to teach Mahjong.
And I must know, and I have to make sure I know all my needlepoint stitches correctly.
But I mean, it's just going to be great
It's like
too,
an EMS call.
because you've got, the senior population so well
I
in our
do.
town, and this will just be another.
And
adjunct
Kathy's
to that.
another social worker, so she's going to be
Right.
great, like to have two social workers keeping eyes on everybody. And, we will replace Kathy when the time comes with a full-time program person.
Yeah.
And we'll look for somebody who has like a BSW or somebody with, therapeutic rec history.
That's great.
So,
But it's important to note that the community center is not just for seniors, right?
Correct.
I mean, there's lots of programming
yes,
going on.
yes.
For all ages. And I saw they're doing movies there and all kinds of interesting things.
Wonderful stuff. Yeah.
Yeah. Well, congratulations.
Thank you. Thank you.
Do you want to give your report?
I will. I know that we have a full schedule, so I'll keep it brief. As Amy said, I did attend the Operation Arctic Blast at Fairfield. Got a lot of good information, made some nice connections. I'm going to give a shout out to Silver Hill. You guys did an amazing grand rounds on depression and anxiety in later life, and it was fantastic. So I want to thank you for hosting that. That was great. That was on January 28th. Our numbers are slowly going up. We have a new case management system, so we were able to kind of condense clients who no longer use us and new clients. So Jackie's numbers have kind of changed. I have 222 adult and seniors, and she has 297 total. people. That's including children and adults. So rather than breaking it up, she's just sort of combined them. We've had 4 domestic violence cases in the third quarter. Our vulnerable population list has also decreased to 74 because of going through our list, and people have either passed away, moved to assisted living, moved in with family. Our numbers are more true now. We had 9 energy assistance applications this month, 53 last quarter. So we are at about 63 and still going. That goes until May. Our financial expenditures, we spent about $500 on home utilities and $1,000 on rent, but that is just for the first month of the first quarter of the third quarter. So that will increase. In January, we had 131 households using our food pantry with a total of 85 shoppers. And we are continuing our grief support and our Life Reimagined, and those are going strong and steady. And I am actually meeting with Kathy today to talk about starting up a Parkinson's group at Lapham, which
Great. Kathy Collins is the assistant director, right, at Lapham, yeah.
Correct. And any other, groups that she feels may be necessary.
And you do those over at Lapham.
Mhm.
Yeah, which is great.
Yes. And that is it. If anyone has any questions, I did give you 5 pages, but
Yeah.
some of it wasn't.
Did you just say what the vulnerable population was? I mean,
It went from 100 and
okay, I mean,
something to 74, 74 solid. They are like known to active. Yeah. We just, especially, after the Arctic Blast conference, I wanted to make sure that we had like the right people with the right contacts and right emergency contacts and that kind of thing. So those 74 are people that I can give their names to CERT and, the
now, of all those
EOC.
74, how many would you say you interact with on a regular basis?
Maybe about 25,
The
they're
80-20 thing, yeah.
Yeah.
The
Which
most-
is, that's fine.
That's very
They
normal.
only want to be, touch base if it's going to be super, super hot for an extended period of time, or if it's going to be very cold. We make sure, is your oil topped off? Do you have water? That kind of thing. So.
Great, okay. Does anybody have any other questions?
I was just gonna ask, it looked like you got a lot of public donations, and I was just wondering if that's how the new website donation platform is working. And whether
It is
that-
working.
Yeah.
It's working. Isn't that nice?
It took a while.
It took a while, but it is definitely working. And I think people really appreciate the pull down choice. Like if somebody has domestic violence near and dear to their heart, or they want to just make sure that it's given to the warm up fund, they have that choice. So yeah, it is absolutely working. It took about a year to make sure everyone knew about it, but it was worth it. Yeah.
I think last year we talked about emergency generators being available. Is that still?
Russ
It's also-
Kimes
yeah.
has those available, and
Yeah.
did he say he had 8?
I believe he did.
He said he has 8, yeah.
Okay.
And they have a staying power of 6 to 8 hours.
Yep.
Before they need a refill, so that would give like EMS or fire or whoever would transport somebody in need of,
Sure.
constant generative stuff, that would give the EMS time to get to a driveway that either has.
And our communities area is the library if they're out of power and heat, or the YMCA, correct?
Correct. And the
Okay.
YMCA, I don't think is available until it's actually a state of emergency. And then I think it's downstairs in the yoga studios. There will be cots, et cetera.
Right. So I'm wondering if it's important, as a community, or communicating to those vulnerable populations or individuals if they need, if their power goes out this
Yeah.
weekend or anything of that nature, this is the place to go. Or this is the
Yeah,
numbers.
those are the phone calls. And most of the vulnerable population is on the call out list on, is it Everbridge? Is that
Everybody.
Everbridge? Yeah.
Okay. Thank you.
I should have mentioned that, well, you mentioned the budget process, that you've got 4 times you need to present your budgets, and you've done 2 of them
Yes.
very successfully, and the Board of Selectmen just approved the budget at their last meeting. And so tonight is the,
Thursday.
Thursday, sorry, right, I got it.
Thursday.
I got it wrong, yeah, tonight.
Because, yes. Yeah.
Come back tonight.
Tonight is the Arts. I think tonight is the Board of Ed. Not.
Yeah, so budget moves, yeah. And then there's, you guys, so you have to present to the town council and then
This
No, it's-
Thursday is the Board of Finance.
Board of Finance, right? Right. And then those will be approved, hopefully, in April. But it was very seamless. You did a wonderful job. I was there for both of them and they just did a terrific job of just outlining the programs. There were some good questions, but everybody seemed very enthusiastic about everything that we're doing.
Yep.
Which leads us to everything that we're doing, which is the assessment program at Silver Hill Hospital. Thank you, Liz, for being here and Jason as well. And I guess I would just turn over to you if you
Great.
want to make little introductions and
Sure.
then get started.
My pleasure. Thanks for having us here today. We did make this presentation to town council. Was that last week or the week before?
It was
Everything's
last week.
running in together.
Yeah.
So I have the presentations printed out, but Jason, I guess you'll want to share for people that are also on Zoom, right? Do you have
Yeah,
a-
I can.
Do you want me to? Easy for him to do it? Yes.
I think so.
Right.
He just shares the screen. I
Okay.
think.
Yeah, I'm happy to. If it's okay with you folks, let me just
Yes.
navigate the tech here for a second. Sorry about that.
No. Sorry, I didn't. I
Do you have an
maybe put
extra-
you on the spot
Do you
here.
have an
but
extra copy for
I do.
Mike?
Sure.
Mike?
So how's this? Can you all see what I'm sharing?
Yep.
Yep, perfect.
So Liz,
Okay.
how long have you been with the program now? I know you've been at
So-
Silver Hills. a
Oh, sure.
while.
I've been at Silver Hill for about 2.5 years, and as part of the advancement department. And just this spring, I took over the role of Director of Community Relations. I also am a town resident. So that some of these programs I've known about before I took on the role just from living here. But I think I'll let Jason start the presentation, and just to say that if you have questions, feel free to ask. I think this can sort of be casual. Many of you have already seen the presentation if you were tuning in last week, so feel free to raise your hand if you have any questions. And Jason, I'll turn it over to you.
No, thanks, Liz. And like Liz said, look, this is real conversational. So if at any point, just stop me, flag me down, and we can talk through anything you want. But we kind of wanted to start with just sort of a level set of where we are in terms of the towns involved and the slot availability for the towns. Weston was an early adopter. They have half a slot a week. You may recall that Westport is new to us. Liz, did Westport come on last year?
Yes.
2020. Yep.
They joined
they-
in February though, so they're a little bit of a different, their year looks a little bit different than the rest, but yes, last.
Yeah, that's right. And then, so they have one slot per week. And then, of course, the remainder go to the town at 3.5. And just as a reminder, the way the slots work, the funding that's set aside for that ensures our availability. That said, we've had weeks where we don't fill every slot. You probably know that. We've also had weeks where we have more patients than we have slots. That's fine too. We're just happy to work through it and see whatever patients we need to see when they need and want to be seen. In terms of program data, as we look month over month from inception, we've generally been pretty flat. And if I put a trend line in this, which I had done in an earlier version, it's almost exclusively flat. One thing I will point out, you look at, say, June forward, so June 2025 forward, we're running a little bit lower than we have in the past. We think there are some opportunities there from a marketing perspective, and we'll get to that a little bit. And I think Liz will talk to that probably better than I will when we get to that discussion. But I think sort of the main theme here, though, is peaks and valleys. When people need the program, they need the program, and it's available. And then there are times when it's a little bit quieter, and that actually tends to be the summertime, and we'll talk about that a little bit when we start talking about age too. But sort of back to the peaks and valleys. Sorry, I'll switch back. If you look at September, October of 2024, those were high numbers, and that was sadly on the heels of tragedy in New Canaan. Individuals who completed suicide. So when the demand was there, the capacity was there. So that's, I guess, if there has to be a silver lining in any of it. It's the fact that when folks needed the service, it was there for them. We of course wish it didn't need to be, but it is. But again, to the point of how we can look at the last 6 months and improve. One of the things that we noticed from inception was a big buzz, right? The program started, there was a lot of activity on social media. It was pushed out not only by us at Silver Hill, but by you folks, by the town. It was really, really, really well received. In looking at how we've communicated it collectively, not just Silver Hill, but collectively, we don't feel as though we've really optimized what we can do. So there's a lot of opportunity, like I said, for improvement. And again, we'll get to that. I spoke to this. One of the things that the town wanted to see, the town council wanted to see, was age distribution. And I know you've all seen this in the past, but we're looking at it a little bit differently. So this may be a chart that's somewhat unfamiliar because we wanted to look at it over time. The blue being 22, 23, orange being 23, 24, and then gray being 24, 25. So no surprise, and it has been consistent. This is a service that is really heavily utilized by younger individuals, and we're thrilled that we're able to do that. It's a population that is really underserved, and when we think about underserved, you think of traditionally underserved communities, and maybe New Canaan doesn't come to mind when you think that. But in reality, when it comes to mental health care, the population, regardless of where they are, but that population under the age of 18, and especially under the age of 12, is very underserved. So we're able to fill that gap, which we're really excited about. One of the things that the town council was very interested in is cost, and as they should be. So what we did, we looked back to inception back in 2022. This is the cost to the town. This is not the total cost of the program, but this is cost to the town per slot. And remember, slot is availability, it's not visits. So initially, those were ARPA funds back in 22, 23. And then after that initial infusion, we then divided out the funding. So the town had a portion, the Board of Ed had a portion, the foundation had a portion, and then of course we brought in other towns. So you'll see that cost per slot to the town has continually declined all the way forward into today. That number is lower.
Jason, can I interrupt you one quick second? I
Please.
just want to, everyone remembers that we started funding the program 4 years ago and it was $50,000 a year. And then this year it was $40,000 because of the share amortizing of the costs over those towns. And we also, 25,000 of it was opioid funds, right? And then 15 came from human services. Just that reflects that.
Right. And you'll see to your point, in 24, those numbers started to come down, and a lot of that had to do with the fact that Westport joined the program. So that was a good thing overall. Good thing for Westport. Good thing for us.
Jason, the cost per slot, is that off the $15,000 base that's coming from Human Services, or is that off the $40,000 base that's coming?
Full
Well,
cost to
also-
the town, in the town
It
budget.
also includes, and it costs,
The town budget.
it probably includes the money that comes from the foundation as well, right? Or not?
No, this
just-
is actually just the town.
Might include the Board of
I
Ed.
think you just shouldn't say the town budget, you should say full cost, the 40 grand, just say the 40,000. It's off the 40,000 because those two grants aren't in our town budget, they're grants.
Right, okay.
Just to. be
Thank
very
you,
clear.
Deanna, for
Just to
being
be
here.
very clear.
Our first selectman, thank you for being here. But can I also thank Mike Dinan for being here because he's over in the corner there. And we changed our meetings so that we could be able to go to Mike's Coffees on Thursdays. And we're just really glad that you came. Thank you.
So continuing with the theme of cost, that last slide was cost per slot, and now we talk about cost per visit. And again, so that green line is a trend line, and as you can see, pretty flat. Some peaks and valleys. August 2024 sticks out as a number. It was an odd, by odd I mean unusual, month where there was only one visit. But for the most part, we've seen that cost per visit remain pretty flat. Now, this slide is a little bit different. So let me tell you what we're looking at here. Historically, we've just looked at the plain cost to the town. This is actually the cost of the program, and then the sources of funding in each year. So those numbers at the top, if you go back to, on the left side, that $295,000, that was the cost to Silver Hill to implement the program in that year. And then you had some increases, 330, 320, and then back down to 311. And then that is stratified by funding source. So of course, if you look to your left in that fiscal year 22-23, town of New Canaan bearing the most of that because it was that one-time ARPA funds. Fast forward to 25-26, the fiscal year that we are in right now, that's a projection. You'll see that number is lower. And to point out, that green bar in there, that is essentially the cost of the program that is not picked up by a funding source. Those funding sources being, again, the towns, the Board of Ed, the foundation, and that is essentially the cost to Silver Hill. We have individuals we have to pay, and we're very, very happy to do it. But I did want to represent it so that everybody could see that there is a cost absorbed by the hospital. And like I said,
Jason, is this, when you say cost, is this direct cost, indirect cost, total cost, including management allocations? Is this all in cost or is this direct cost?
This is just direct cost. Andrew's time isn't allocated to this. My time isn't allocated to this.
So it's your psychiatrist.
This is direct clinical cost and direct program oversight. You all may have met Katie Suss in the past. Katie is fully allocated to this. Obviously, our psychiatrists and clinicians who see patients. Does that make sense?
Does anybody have any questions about this? It's a multicolored chart.
Lots of color.
Lots of color. It's very straightforward.
Okay. Then one thing we also we had some questions from some town council members. We wanted to be able to answer them. Primary, which was a concern, not a concern, but a question about whether or not we are able to find clinic or outbound referrals clinicians who are able to meet the payment needs of the patients. So a lot of patients, they want to use their insurance. Some don't. But when you look at the availability of clinicians in the New Canaan area, there are a number of providers, psychiatrists, psychologists, social workers, therapists, but many of them don't take insurance. And the reason they don't take insurance is because insurance reimbursement is not very good. So one of the biggest struggles that we have is ensuring that we're referring patients to providers who will take their insurance. So the question was, are you successfully able to do that? Good question. And the answer is yes. We never want to put a square peg in a round hole. So if we refer somebody who needs to use their insurance to a provider who does not accept insurance, that is not helpful. So generally speaking, just shy of 50%, so 47% historically of our patients are referred to a clinician, a provider, who will accept their insurance as in-network. That's in orange, and then you sort of look to your left. OON is out-of-network insurance. These are insurers these are providers who will accept insurance on an out-of-network basis, which you may or may not know sort of changes the cost to the patient. It might be a little bit more expensive, but it is still insurance-based. And that's just shy of 30% at 29. So collectively, just shy of 80% of our patients who we see through the assessment program are looking for a provider who accepts insurance, and we're able to find them. We're able to find them a provider who does. It's one of the bigger challenges, and quite honestly, it ends up taking up quite a bit of time because we want to make sure somebody lands in the right place. But we're generally successful because we kind of know that network. And just as a practical.
But you're right,
matter.
Jason. Sorry, you're right. I was going to say this is sort of a hidden gem and why the program actually really works. A lot of times finding the right provider takes much longer than the actual assessment takes, because that's where the real beauty of this partnership happens, is that we've got staff that knows providers that are in town and will be able to not only the insurance needs, but some people want virtual visits, some people want to visit therapists that are not in town. They would prefer to be, go to the next town over. There's a variety of things that we have to sort of take into consideration. And if you're talking about, do they need med management? And there's a variety of things. And so I think the relationship that Silver Hill has with these clinicians, whereas they may not be taking new patients if patients are calling individually, but if we're calling often, because we have a relationship with them, they'll take new patients. Maybe they want referrals from us. Maybe, there's a variety of reasons, but it can be quite time consuming. So when you were asking again about what type of, where's some of the money coming out of the budget, Katie says this is full-time work for her, and always out in the community trying to meet new therapists, new social workers.
I've heard this anecdotally, but isn't it important that one of the advantages of the program is that the providers, the issues with the patients, and you can really connect.
For sure. And that it's evolving, and that's something that we have to continually do, because also providers will, 1 month they might take insurance and the next year they don't anymore. And there's always new people coming to market, but absolutely. So if there's someone coming to us that has, OCD, then we want to find someone, okay, well, who works best with OCD in adolescent care? Oh, we want someone that's female. Okay, let's find someone that's female. So yeah, absolutely. That's sort of one of the main tenets, I think, of doing this, is not only helping the patient when they're at a time of need, when they're first coming in, but is really trying to find a relationship with a clinician that works.
Not enough attention can be placed on navigating, because if you're in a network and you go online, those networks change daily, and you think a physician is in network, they're not in network. And so having someone that can help navigate through that is a tremendous
the burden
benefit.
of the folks that are in network. I mean, it's often, oh, sure, we have availability, but it's in 3 months or something, truly. And that's not helpful to, that's not helpful to a patient. So not only are you accepting a new patient, but can you see this patient next week? And that's, where a lot of the real value comes in.
Mm-hmm. Especially in a time of crisis,
Right,
When
right. Okay, Jason, sorry.
So one thing we did want to look at and share is the results of our surveys. And I know you've seen this data in the past, maybe in a little bit of a different format. But generally speaking, people are pleased. On the left, we're talking about positive experience with clinicians. And to be clear, just in terms of the colors, the only color that's really, I'll say negative is the answer no. The others are yes, definitely, yes, mostly, and yes, somewhat. I don't like somewhat. I definitely don't like no, but the others I'm happy with. And when we talk about experience with clinicians, people are thrilled. Getting an appointment within a reasonable time frame, people are still very, very happy. Where we start to see a little bit of a trail off is on the right there, referrals meeting the needs. And that, unfortunately, is the one over which we have the least control, because we're able to plug people in. We're clearly able to plug them in a timely manner. But then we kind of, it's at that point, we're a little bit less hands-on, because that meeting between the patient and the clinician has to happen. And for a number of different reasons, sometimes it doesn't. To be quite honest, sometimes it's the responsibility, and I hate to use the word fault, but the fault of the provider to whom you refer. In some cases, honestly, it's the fault of the patient. That connection just doesn't happen. We do the best we can to make sure that the patient lands in a good spot with a provider who's going to be there for them when they need them. I don't know, Liz, if you can put a little bit.
Sure, I agree. I think if not, there is always an openness and a willingness. We've had folks that we've made referrals to, and it didn't fit, and then we try again. So I would say it's an open conversation. Occasionally we've had families that come in, we make a referral, they never make an appointment, they don't do it, and then they come back. So we have a few of those sometimes, but there is an open conversation with families. They have our number, they have our email, and we are happy to continue working with them until their needs are met.
It could just be personnel.
Oh,
right? Like, I mean,
absolutely.
sometimes you meet with like any kind of doctor, and you're like, ugh. don't like that
Absolutely,
doctor.
for sure.
For no reason
Yeah.
except.
Yep. I mean, I've heard a variety of reasons, and I remember one was like, oh, I went to that clinician and she was, I saw someone I knew in the waiting room. Like, okay, well, sorry. So, you find someone else. So there's all sorts of reasons why, people might ask for a secondary referral.
Yeah, it's not like getting a hip replacement where you're just happy to have a doctor who has a great reputation. Sometimes there's an interpersonal aspect.
Me, yeah.
Russ
A little
is
bit
taking that
different.
personally. 'cause
Yeah,
we
I
had
took
to-
that personally.
Hip replacement. But did you like your hip replacement?
It was great. Thank you.
You're going back soon?
No, thanks. Maybe the rotator cuff.
Jeez. Sorry to interrupt.
It's okay. We did want to look a little bit at what individuals present with, and we sort of hesitate on these numbers because we're not diagnosing, to be clear. So these are not diagnoses. We're only spending an hour or so with a patient, and that's really not enough time for us to get a full history and really dive a little deeper into the patient and their condition. But this is generally speaking what they present to us as their complaint. Yeah, I'm not going to go through every single one, but you can get a sense of what we're seeing. Obviously, depression and anxiety being very, very common, which should not be a surprise to anybody here. If you're
The one comment I will make is you'll see substance use is relatively on the lower side, which sometimes surprises folks. But this is what the person self-declares as their presenting complaint. So often after, the conversation is had, substance is a factor, but it does portray itself relatively low on here, but it doesn't mean that it's not an issue.
Yeah, somebody complains of experiencing depression and anxiety, and then 30 minutes deep in the conversation, the fact that they've been drinking for the last 6 months emerges.
Yeah.
So that's not what they present with, but it's a co-occurring.
Do you want to add something?
Jason, yeah, sorry. One of the things that we've talked about here as a commission is prevention, early detection, things of that nature early on, and preventing it getting from an emergency situation, right? Identifying it early upstream. So I'm just wondering if you guys keep track of, we used to track suicidal ideation rates as something that we would talk about here at Showed Up Hospital. And it was much higher than 17 that's appearing here in your data. Do you have anything, not like a return on investment, do you have anything that shows that since the assessment has been in place, the number of suicidal ideations that are showing up in hospitals that EMS has had to respond to or things of that nature has actually gone down over time? Do you have any kind of analysis like that shows not a return on investment, but that we're moving this upstream in an earlier detection before, and it gets back to your chart when you have your program data that after the suicide and we see this peak.
Yeah.
Well, is there anything that, preemptively could have been done as we're tracking this? So those are the kind of questions, not to answer, but to, as a commission that I'm personally, I hope my peers are interested in seeing, and that, the needle is actually moving in terms of early intervention.
I think that data point would be terrific, and I think you'd all love to know it. I think actually managing it and figuring out is somewhat difficult. One, just given the numbers of folks that we have here at the hospital. I would say similar to, yes, maybe we see that this percentage is lower than you might think, but again, someone might come in and present and self-declare, I've got depression, anxiety, but don't admit to the suicidality. And that is always a challenge, is to try and determine what are those actual numbers. I would say you're correct. One of our main goals is to keep folks out of the emergency room. I think there's a lot of work to be done there, and that is around awareness of the program, trying to get folks to call earlier and to call us instead of calling 911 or calling an ambulance or showing up in an emergency room, because what we know about that is that's not a great situation. I mean, the emergency rooms are not great places for this type of, you're already in a panic state, and then showing up in an emergency room where there's few beds, especially for young people. So anecdotally, what I can tell you is we've had a handful of families that have been extremely grateful for our service because their next step was the emergency room. Whether they were identifying with suicidality, I can't necessarily say that, but I think it was at a level to where it felt urgent enough for parents where they were unsure what to do, and very grateful for the program and helping to sort of put the pieces together for them before they had to reach that next level. And maybe I think this is a great topic. It's a good, we're actually analyzing our survey right now to make some changes moving forward. And maybe that's a question that we can all sort of think about together to try and determine how do we keep sort of numbers that are meaningful on that. And I think I'd be happy to hear feedback, but I hear you. It'd be nice to have some real evidence.
Well, we get to report on how many New Canaanites reported into the local hospitals with the suicidal ideation rate. So tracking that to preemptiveness, right? Hopefully you see, and this is how we got started, right? Thinking about because of the suicide in town, seeing that, we're spending good money for the urgent assessment, but more on the assessment side to prevent a younger adult ending up in emergency and psychiatric emergency services, screening services, and that kind of vortex that they get sucked into.
In an ideal world, it would be great to be able to ask those folks, did you ever use the assessment program? Did you know about the assessment program? Why didn't you use these were the things that we want to know. So I think that we can maybe try and dig a little bit.
Or work with North Stanford Hospital. I'm happy to be part of that, or Norwalk Hospital. So maybe you get more data for especially a New Canaanite that shows up.
And aren't you also educating the police, meeting with, to try and talk about?
I mean,
the program
absolutely.
itself?
Absolutely. It's something that we continue to do. But after, I think Andrew mentioned this last time, like after 911 is called already, it's too late.
Do you know how the schools handle this? So teenager walks in to see the nurse or the counselor at school and says, I have suicidal ideations. Do we know whether they think about first calling 911, or do we know whether they first think about contacting the parents or contacting, making the assessment program?
They're required to address it, obviously. And generally speaking, they call us first. We've got a really nice relationship with Susan Bliss. And then often at that point, sometimes Andrew gets on the phone and we have a discussion, try and determine, while we are not, I want to make sure to state this for clarity, we're not an emergency room. And if there's an acute situation where there's a pressing need immediately, we're not the place to go. However, kids say things. And sometimes kids are at school and either they self-report or a friend or a teacher reports, or they see evidence of cutting or something. And in those instances, we've had situations where we make same day accommodations. We've had someone come in an hour later. Sometimes we'll say, hey, you should go to the ER. But there's been a few instances where, and this is solely because we've got such a nice relationship with Susan Bliss, that there's sort of a trust factor there that we trust her, so her assessment of the student and perhaps the parents, and we're able to intervene before it makes its way to an emergency room.
Are any of these numbers repeat clients? And at what point do they have to get a new assessment if they come in twice?
We've had a handful of people come in twice. Sometimes they've come in twice, a year later, and then absolutely they have a new assessment. But these are all individual But you can, sometimes people will come in and say, I've got 5 things, right? So it's not mutually exclusive. You can present with as many complaints as you want. But we have some repeat, but the number's relatively bad. Often we see though, someone comes in and then they send a family member in. So we definitely see situations where one person utilizes it and then they send in a family member.
Interesting.
Okay. There was a question from the town council on our ability to recover funding from insurance companies when we bill them. What this simply shows is that while we are generally able to bill, our actual reimbursement tends to be very low, bordering on non-existent. The reality is that for the service that we provide, and Liz, maybe you can throw some color on this too, but generally speaking, for the service that we provide, the insurers are just not reimbursing. But we do try to mitigate the cost by submitting to insurance companies. Just the unfortunate reality is they don't cover the surface.
No, I think that's pretty black and white. That's fair.
Sadly.
Welcome to healthcare.
Yeah, I was just gonna say, Russ can comment on that. Not being paid.
But I spoke earlier about our identification of opportunities to improve marketing. And Liz, do you want to sort of run with this?
Sure. You know what? I think some of this is, this first slide is the need is clear. I don't think that I have to spend much time with you all to explain that the need is there. But if you're interested in some of these numbers, the hospital just completed our community health needs assessment that we do every 3 years. So some of these numbers are coming from surveys that were done in the community from different providers, not just within New Canaan, but within Fairfield County. But we see every day, I think anecdotally, it's that there is a need for the program and for referrals. I think when we talk about the younger patients that we're serving, there's new stressors at that age, but that's also when emerging symptoms come from at that age point when people start to suffer from mental health issues. That's sort of the age frame where they show up. So it's good for us to be able to see those patients. As Jason alluded to earlier, we have seen a little bit of decline, not huge, but a little bit of a decline. And I think what that tells us is it's time to start pounding on doors again and get back out in the community. And that's not only our job, but everybody's job is to continue to remind people, residents of the town, about the program and its availability.
Can I ask this a question?
Sure.
It would be best. Is this all about the referrals?
Oh,
You asked,
yeah.
who
Yes.
referred you?
Yeah.
Okay, it's it's interesting because Jackie on any given day is telling families.
Oh, I'm sure. Oh, I absolutely agree.
it's
I believe it.
yeah.
It's really hard. I have to say, these are also just to remind everyone, someone's coming in for an assessment. They're there for 60 to 90 minutes. We're trying to get some data for them, but I mean, they're there because they're there for an emergency. So asking them, well, who did tell you how to get, it's like sometimes they say my mom or my neighbor or whomever, but where did it actually originate from? It's difficult. We're just reporting on the data that they presented to us. We know that, Katie and I, we speak with your office. We're continually in touch with you, and we're continually in touch with schools. And so that's, I think we did have a discussion about during COVID times, town was maybe residents were a little bit more in touch with Health and Human Services than maybe they are now. So maybe where they say they hear it from is not Health and Human Services. But I think the actual real point, though, is that we want to make a push again to make sure that residents are not only familiar with the program, but feel empowered to use it. And that's the real key here, is to make sure that they feel comfortable coming to the hospital. Some of the questions that we get when folks come, are as simple as like, am I going to be around other patients? Are people going to see me? Where do I park? Are you going to force me to take medicine? Are you going to make, do I have to be admitted after I mean, there's a range of questions. And sometimes they even shock me where I'm like, oh my gosh, we really need to get back to to the very basics of what this program is and what it does and who it's for. Yeah.
You're not scary.
No, we're not. I mean, we're really not. And Katie Suss, who's, meets our patient, she's fabulous. And especially I think that's a consideration for our younger folks. And so there's been discussion of how do we manage that and I think one of the ways is just to continue to be out in the community. And so people can see who the faces are and what we do and to see that, the program is available while its intent really is to help people stay out of, potentially the ER and real urgent situations. But what we want to make sure is that people are using it before it gets to that point, right? So if they have a loved one or they themselves are experiencing difficulties, that they come and see us, beforehand. So we're working on a few different things at the hospital to try to get the word out again. We've gotten a new director of marketing at the hospital who's wonderful. He's going to work with us on social media and some new print materials that are a little more maybe customer friendly. We've got a couple events coming up in February. I've got an invitation going out this week to all the clergy and faith leaders in the community to come have a cup of coffee with me and discuss the program. We know that often when people are struggling, they turn to their churches first. Dr. Amy Swift is doing an event at the high school at the end of the month in conjunction with New Canaan Cares about cannabis. And so I think when we're out in those types of environments or at the library, we can continue to talk about the program, but just want to emphasize that hopefully everyone bears some responsibility and will continue to sort of amp up sharing the program and its use.
Curious, you have like anonymous testimonials?
We do have
Part of the
testimonials.
marketing, because some of that seems to me is a way that someone sort of sees visually that, oh, we had a problem, we went there, and it was not to be admitted to Silver Hill, but it was then directed to here we go.
Absolutely. Well, I mean, that's a really long testimonial we have here at the end. This is from
Last page, I
Susan
didn't
Bliss.
get there.
But we do have testimonials, and that is part of, we'll utilize that for sure in our marketing plan. And I think that John Kriz has also offered to, he's been interested in writing a story for us on the assessment program to try and really meet with some of the families that have used it and discuss, because word of mouth is so powerful, right? Like we can all do everything we can, but being able to share anecdotal stories and actual stories. I mean, so the idea there is to have people across the spectrum, right? So you have someone, an adolescent, where you have maybe some college kids that were struggling when we do see that, right? Like over Christmas break and Thanksgiving break, the college kids are here, especially for like, oh, I was doing okay during the summer. I was doing okay in high school. And then all of a sudden they get into an environment which is much more difficult to deal with. And then they're at the assessment program. And when we're talking about loneliness, so we also see when we look at these numbers that that's great. And I'm happy to hear that we're offering support for our sort of young adults and adolescents. But when we look at the numbers that are a little bit lower, as people get older, I mean, there could be some answers. I mean, maybe some of these folks already have therapists and don't necessarily need us, but I don't think that covers everything, and so trying to get out there and make sure that, at the schoolhouse or older adults are available and welcome to, I don't want to say that this is great that we serve that population, but we serve everyone.
Well, there may be a stigma too, for older people about reaching out for something like that.
Well, I think there's some power in the first hospital where I cut my teeth. It was called psych screening at that point in time. That's how dated I'm making this. But it was very important that the waiting room be private.
Yeah.
Because when you get older and you're all sitting in a waiting room, everyone has an issue that they're dealing with. But when it comes to young children or when it comes to a young parent, they want it to be private. They don't want to risk seeing someone else that they know and things of that nature. So we made it a
agree.
point for the adolescents that they had a private
Yep.
waiting area
And-
to go to. And there's, the stigma is still there.
Yeah.
That my child is,
Yeah.
may have a problem. I would just
Yeah.
reemphasize any feedback.
Yep.
From what we saw, was very powerful.
No, that's
and knowing
great
that was
to say
private.
that, you'll be given privacy and
Exactly.
there's a private entrance and here's where you're
Exactly.
going. And it really is, it's in our admissions building. I mean, I can't guarantee like no one's going to see you, but
Yeah.
it's not, you're not in the hustle and bustle of the actual hospital setting. So we also talked a little bit about, I'm going to try and get some college interns this summer to do some work, really being out there in the community, do some social, Instagram and do some social media. And then also you talk to some coaches. I think there are endless possibilities, but I think what we find is when the message comes from us, it sort of goes in one ear and out the other. And unless someone is in a time of need, they're not necessarily like following Silver Hill. But they are following members of the community. So as much as we can get sort of ambassadors to talk about the program, I think it'll be.
Do you think that people understand that for New Canaan residents, it's free?
I do, but I have talked to clinicians that actually even work at Silver Hill sometimes, and they're like, "Oh, so it is free." I mean, "Oh, so we do see kids," and that's not. I mean, and so there's again, I kind of go back to, and unless you need it, I don't. And you have been told this a million times, and you've got the flyers, and you've done all the things, and it's difficult to sometimes tell.
There's a high school intern, New Canaan High School intern program too. I don't know if you've utilized.
You know what? We haven't,
just to get.
well, no, it is.
word out.
It's great. And I think that I was actually just talking to Dr. Gerber about this last week because we've got some high schoolers that are part of the New Canaan Community Foundation that we're working with. And again, it goes back to that privacy part that we want to reduce stigma and we want to have students on campus, but we also don't want to have students. It's difficult to try and determine like, okay, we have to protect our patients. Yeah. Yeah.
In case they see peers that are.
Yeah, okay.
So like, I understand.
Yeah.
But I just helping with some marketing.
I think that
not
you're
as
right.
much
And the thing is
on-site.
about the social media stuff, they don't have to be on campus.
Right.
I mean, they can do this,
Right.
they can do this, but wherever.
From the library. or
Is there any
some
thought of
place.
bringing in another town? Or is there room for that?
There has been thought, Jason, I think you've talked to Ridgefield, Darien, maybe. I think we haven't.
Yeah, I mean, we've been really trying to convince Wilton to get on board. We've had conversations with Darien. If there were conversations with Ridgefield, I haven't been on them. We were really thrilled to get Westport, but honestly, to that point, I don't believe we know we have not hit critical mass in terms of scale. So adding more towns is definitely something we're pursuing, and have been, and will continue to. At the same time, we don't want to be a Goliath either. Not that I think we're approaching that, but at the same time too, we started as, the New Canaan Urgent Assessment Program, and we don't want to stray too far from that.
Yeah. I mean, because we really are tailored to meeting the needs of our town. So I agree.
I have two questions, Commissioner Alyssa McKenzie. My first is, it sounds like you assess dual diagnosis. Do you have trouble finding referrals for dual diagnosis? Because I do know that can be a real barrier to care that families face.
Not really. And I think actually Dr. Gerber just was talking about this last week. That really is the norm now. I think the percentage that he said, maybe actually was just doing a webinar on this last week, that like 80% of folks actually really have, a dual diagnosis. So if it's something very complicated, if we're dealing with schizoaffective disorder or something to that nature, sure, we've got fewer referral sources. But if we've got someone with ADHD and anxiety, yeah. That sounds about right. We've got some, I don't, that hasn't posed an issue for us right now.
Great. My other question is, I know you're free to the client, but what happens if like you have insurance, you're underinsured, you don't have insurance, and you truly can't afford the care afterwards? Like how difficult is it to find a provider and get coverage for those clients?
Thankfully, we haven't really had that yet. And I think if we did, we would probably have a discussion with the folks here and with Health and Human Services if there was a resident that was really in need. We've had an instance once in Weston where they paid for some services that was needed from a resident. And I would say, you know, Husky is that's where, you know, we have more difficulty is trying to find good referrals that accept Husky. So we're continuing to do it. Jewish Family Services just opened up I think it's open, at the YMCA, and they do take Husky. So that's a great partnership. So we're seeing, you know, a little bit more of it, but they have a nurse practitioner on staff. She's not a psychiatrist. So, you know, it's evolving. We're doing the best we can, but it's you know, it's not as you all know, it's not a perfect system.
Yeah, it's difficult.
Tracy Hamill, Commissioner, just one quick question. Do you know of any similar type of programs elsewhere in either the county or in the state?
There is a state-run program that is regional in nature, and funding is allocated based upon essentially its providers per capita. So there's no such program through the state here in Lower Fairfield County. Interestingly, there's kind of a reason why, because the state looks at simply that number, providers per capita, and says, oh, well, there's tons of mental health providers in Lower Fairfield County. What they don't take into consideration is the fact that the majority of them don't accept insurance. So while there are providers here, it doesn't mean there's not an access problem. There's still an access challenge. It's not the number in total. It's the number who accept. But I'm not, Liz, maybe you are, but I'm not aware of any specific programs just like this.
Yeah, I mean, this is a pretty unique. I think I say all the time, and we should be so proud of this offering. Actually, just reached out to the Newcomers Club this week to make sure that they knew about it and are reminding new people that move here that this is accessible to them, because it really is. I think it's really amazing. I've seen a few instances before where, like I think one of our social workers that's at the hospital, her kids are in Chapakos schools, and they have, not to the same degree, but they've got a social worker on staff that will do something similar and has access to make some outside referrals. So it's not to say no one is doing this, but I don't know offhand of a similar framework.
Well, Liz, is I think some of the insurers right now have a telemedicine option.
Sure.
So if you're insured by X, Y, and Z, here's a telemedicine number that you call, and you can have a Zoom, to Tracy's point, you can have a Zoom conference with the social worker instantaneously on Zoom, and then they can reach out who's ever in network and make a referral. So that's where I see some of the insurance companies going for that. So, but in terms of, I think this is very unique that we started this as New Canaan. We should be very proud of it. And I think as you get more and more data to show actual returns and hospital preventions, hospitalizations, I think that's going to be very powerful.
I think I absolutely agree. And I also think that from our marketing standpoint, Silver Hill has been really a place that's a little bit, over the last handful of years, or maybe even decades, that it's a little bit isolated from the town. I mean, it's in the town, but no one's really having conversations about it. But part of my role and part of my responsibility is to be out there in community and having talks that are accessible to families that maybe on a less acute level. We're going to do something in May and then again in September about folks that are, young adults that are struggling with that transition into adulthood. And that's a conversation that I think a lot of people can maybe relate to.
Sure.
And when we have programming like that, where you draw on the community, then they can start to rely on Silver Hill as a partner and somewhere they look to as a resource, and to be this sort of wealth of knowledge. And that doesn't mean to say that you need to be admitted, but that it can be a resource. And I think that as people start to be comfortable and to know a little bit more about the hospital, they hopefully will feel more comfortable and want to come and use the assessment program. But we're still working on that stigma reduction and really the comfort level of people wanting to talk about it.
All right, well, I think we have to wrap it up because we have some other business, but unless anybody has the last question.
No, thank you, Liz.
I appreciate
so
things.
much.
I think Jason had something to say.
No, I was just saying thank you.
Oh, okay. Sorry. Just wanted to make sure.
No, we really
Yeah, yeah.
appreciate it. And we
Oh.
appreciate our partnership and it's been
My
incredibly
pleasure,
valuable to the
and
community.
it's, let us know whenever we can come back and we're
Thank you.
talking frequently to a lot of you, but please, if there's anything else that we can do, happy.
And vice versa.
Yeah, okay, perfect. I
Thank
think
you
I'll-
very
Thank
much.
you
Yeah,
guys
thank you.
for taking the
My
time.
Okay, so we just have a little bit of business, right?
Yeah.
Old business, I just wanted to mention about commission liaisons, because last meeting we announced all the new ones, but we have a couple of people who are going to join partnerships. And Russ Barksdale is going to be in partnership with Alyssa McKenzie on the DVCC.
Junior partner.
A junior partner.
Alyssa.
A junior partner, that's good. And Tracy Hamill is going to be working with Peter Campbell on Silver Hill Hospitals as she leaves. So we're really grateful to all of you because everybody's got a responsibility, and we'll be looking into doing some evaluations and conversations and then reporting back in June and September about those relationships and those organizations. And then I just wanted to ask, John and Jen are heading up the AARP Livable Community Initiative, and I think you have a very brief report. You said.
Yeah, I was gonna say, we've met and we've gone through their materials, and our next step is to meet with AARP directly so that we can talk to them about the application, and we could try and tailor. We've looked at what some of the other towns have done, and their situations are a little bit different, and so we just want to try and be as efficient as we can with the application process.
Anybody
we'll
have
do
any
that.
questions
And-
about that?
I was just going to say, the other thing we were going to ask them about is their livability index, because they have this index and the towns are rated, and New Canaan, we're kind of interested in why New Canaan is where it is, but some of it may be affordable housing issue. But when we look at the other towns and how they're ranked, we thought we might as well take that as an opportunity to at least get a little more information about that.
You want to add anything?
No.
Jen hasn't
John is
talked
so
at all.
thorough.
Too busy taking notes.
Sorry. But yeah, that's exactly where we are. John summarized it very well.
Well done.
Thank you.
Okay, and so I just also want to mention about some new business. We're very grateful to Jim Lisher for his leadership of so many activities related to seniors, and one of which was the creation of our seniors mental health subcommittee. And so we have Alyssa and John who are members of it, and I'd like to nominate John to be chair of the committee. So John Knight to be chair of the senior. It was between him and Alyssa, Just
Alyssa
kidding.
saad that was okay.
She did. That's okay.
More than okay.
So I'd just like to put that.
My
forward.
proxy is with Alyssa, so whatever Alyssa says.
It's a partnership, but so I just wanted to nominate them. Anybody have any conversation, any questions or anything? Okay, all in
I
favor?
second it.
Oh, you
Yeah,
forgot.
second.
All in favor? All right, thank you, John and Alyssa, for moving that forward. They're actually having a meeting after this meeting to sort of do some planning. You want to talk about that? What you're going to do?
Well, just to say, we're going to go back through, where we were, and we're going to try and come up with a list of recommendations so we can bring it forward either at the next meeting or the one after. Just sort of summarize where we are and some thoughts on bringing closure to the work that we did last summer.
Yeah, thank you. And actually, it is an open meeting. It's a Zoom meeting, and it's going to take place downstairs in boardroom B or something. And so if you all want to
Yeah,
participate, you're welcome.
Barb's going to join us ex officio.
Yes. Not cool. Anyway, just kidding. All
Camera
right.
does.
So does anybody have any questions about that? No? All right.
Motion to adjourn?
Second.
All in favor?
Nice.
Thank you. Thank you all.
I like how you guys just go back and forth, makes it easy for Ned.
Yeah, right. The same people. Well,
Wait,
Well, I
great.
just looked for Barb for the weekend, maybe that's why, so you might think,
but I do that so often, so I don't know.
oh, yeah.